All right, welcome back. Today's lecture is going to be about the pectoral girdle, and I added the humerus. I'm trying to evenly space out the bones of the body as well as the muscles into these lectures. So let's just do a recap before we start talking about which bones we're going to discuss today. So we previously worked on the axial skeleton. So we did the skull, we did the vertebral column in the back, and then we did the bony thorax. So we did the ribs and we did the sternum. So today we're going to talk about the pectoral girdle, which consists of the scapula and the clavicle. And I'm also going to talk about the humerus today. And then the next lecture will cover the rest of the bones of the upper limbs. So you can tell that the upper limbs and the lower limbs have some similarities. They all start with one big bone here and on the other side, and then here, and then they end with two bones. So in the arms, it's the radius and the ulna, and in the legs, it's the tibia and fibula. So when we became upright organisms, bipedal, when we started walking on two legs, our lower limbs tend to be a little bit bigger because they are what is holding most of our weight compared to our upper limbs. So we'll start today with the clavicle, scapula, and we'll end with the humerus, and then I'll bring in the muscles of that region that you need to know as well. Also, a good time to have the lab activity with you, because when I start talking about the muscles, I will highlight which ones I want you to know. You always have to know the muscle and the action if I go over it, and then the origin and insertion will be highlighted in the lab activity if I want you to know it. All right, so the pectoral girdle. So it includes the clavicle, which is here, also called the collarbone, and then we will talk about the scapula. The clavicle does not have a lot of features to it, but the scapula does, as well as the humerus. The pectoral girdle is what attaches each limb to the skeleton, or the girdle is what attaches each limb to the skeleton. So for the arms, we have the pectoral girdle, and for the legs, we have the pelvic girdle. All right, so let's talk about, there are a couple things that I do want you to know about the clavicle. So again, the clavicle is going to connect the axial skeleton to the appendicular skeleton. There are a lot of attachment sites for muscle, and this is what is going to support our shoulder. So when we get to lab and you are looking at the clavicles in lab, the one question that I want you to be able to answer is, if you're holding a clavicle, can you distinguish the right from the left clavicle? So you may see that on a practical where you'll see a clavicle and I will ask you right or left, question mark. So let me go over a few of the features that are on the clavicle. There's not much that I want you to know, but I do want you to know the orientation. So this is showing you a right clavicle, a superior view, and an inferior view. And the both clavicles have two ends that I want you to know. So I want you to be able to distinguish the sternal end from the acromial end. Okay, so the sternal end is where it's going to meet the sternum. This acromial end, I'm going to show you later, is where it meets the scapula, okay? The sternal end is a little bit straighter than the acromial end, so there's a couple little clues on how you can tell the two apart. The way I distinguish it, and again, what you're going to need to do is use one of those stand-up skeletons that we have in the lab to look and see how the clavicle sits on the skeleton and how it meets the sternum and the scapula. And one of the things that I do to distinguish left and right is to feel for this conoid tubercle on the inferior side. So if you put your finger underneath, so if you go up to one of these skeletons that we have and feel underneath the clavicle, you can feel this tubercle. And that could help you distinguish left and right. It also takes on this S-shaped appearance to it. So those are really the only features that I need you to know for the clavicle and to be able to distinguish left from right. All right, so again, here's a nice picture showing you how the clavicle articulates with the skeleton. So you have an articulation site with the sternum here at the manubrium, and then you have an articulation site with the scapula. The scapula has a bony protrusion that kind of wraps all the way around. It heads towards the front, anterior portion of the body, and meets up with the clavicle. Let's take a closer look at the scapula and some of the features that you're going to find. So when you're in lab, again, grab this bone and try and identify all of these features. The scapula also has a lot of muscle attachment sites to it. So as we go over the features, you will see that they share the same name as the muscle that is attaching to this bone. All right, here is a view of the scapula. You can see both the anterior view and the posterior view of the scapula. So let's work through this and talk about the different features that I want you to know. So the scapula it has a triangular shape to it. Let me put my highlighter on. So let's attack the anterior view first and talk about the features, and then we'll move on to the posterior view. So again, a lot of muscles attach to the scapula. One of them is called the subscapularis muscle, which I'll show you at the end, but there is what's called a subscapular fossa because the muscle is going to reside in this area. So that is the subscapular fossa. There are two bony protrusions that come off of the scapula. I just mentioned the acromion. All right, this is what is going to articulate with the clavicle on the anterior side of the body. That's the first bony protrusion. The second one is the coracoid process, okay? So that is the anterior side. Those are the features that I want you to know. On the posterior side sits two other muscles. One is called the supraspinatus and one is called the infraspinatus. You can think of it as superior and inferior if that helps you too, because the name implies where it's at. So the supraspinatus fossa is going to be where the supraspinatus muscle is going to attach. Again, I'll show you that later in the lecture. And then this is the infraspinatus fossa. And then there is an infraspinatus muscle that will attach there. There is a spine that runs all the way across and comes over to that acromion. You can feel the spine of your clavicle if you put your hand toward your back. Let's see, what else do we need? So the humerus, that is our upper arm bone, is going to articulate with the scapula at the glenoid cavity. All right, and I'll show you this bone on a lateral view so you can see this cavity a little bit deeper or a little bit better. We are going to talk a little bit more in detail about this cavity because it's a very shallow cavity. And you're going to see that because we have so much movement in our arm, we need a way to stabilize this. And there's going to be a lot of things that we'll talk about that help this cavity, the glenoid cavity, maintain support for the humerus. So that sums up the features for the scapula that I want you to identify when you're in lab. Here is a lateral view of the scapula so that you can see a close-up of the glenoid cavity, and you can really appreciate how it is not a very deep cavity. All right, so here's the glenoid cavity. That is where the head of the humerus is going to articulate with. This is going to make the shoulder joint. So this is a ball and socket synovial joint. This is not a deep socket. The fossa itself is pretty shallow, which allows for a lot of mobility, but you lose a lot of stability because of it. Let's talk about the features of the humerus before we start talking about the muscles that are surrounding this shoulder joint. So here is a view of the humerus. We have both the anterior view and the posterior view. Make sure that you always orient yourself first, because you could pick up a left humerus, you could pick up a right humerus. So you need to be able to orient yourself first with any bone and determine if you are looking at the left side or the right side. So let's start with an anterior view. And always remember that left and right is concerning the patient, not how it is for you. But you can take the bone and kind of put it up to your body to kind of orient yourself that way. All right, so you can immediately see that towards the head of the humerus, there's not as many features that you will need to know. But as you go distally down through the humerus, this is where the elbow joint is going to occur. And there are a lot of features there because there's a lot of articulation sites between the radius and the ulna. So I think it's good to start looking at these features in this lecture. It'll make a lot more sense when we start talking about the radius and the ulna in the next lecture. But the sooner you can get a grasp of these features, the better you will be. All right, so the features are the head of the humerus. This is what is going to articulate with the glenoid cavity. It's always worth noting what articulates with what as we move through these lectures. There are two major bony protrusions that happen toward the head of the humerus. One of them is the greater tubercle, and one of them is the lesser tubercle. These are sites for attachment, insertion sites for muscles, okay? And when I go over the rotator cuff muscles, you're going to see there's 4 of them. 3 of them are going to insert into the greater tubercle. That's why it's called the greater tubercle. It's bigger. There are more muscles that attach to it. And then there is one muscle that attaches to the lesser tubercle. As we move down the humerus, you can see a little protrusion called the deltoid tuberosity. This is actually where the deltoid muscle is going to come and insert. Lots of times you can feel this little bony protrusion on the humerus when you're handling it in class. All right, let's work at the distal end of this bone and kind of work through all of these features that are occurring here. And again, a lot of these have to do with articulation sites with the radius and the ulna. So be sure to start to learn these sooner than later. So if we work from the lateral side of the humerus, you can see the capitulum. That's this bony feature right here. Okay, that's the capitulum. And then next to the capitulum is the trochlea. Okay, the trochlea actually has 2 bony protrusions, so it is this whole structure right here. That is the trochlea. All right, so the capitulum and the trochlea are going to be articulation sites. You can also see the trochlea kind of wrapping around to the posterior side. So it's one kind of smooth structure that goes from the anterior side to the posterior side. And then as we move medially, you're going to see a medial epicondyle. All right, that's this bony protrusion right here. and right here. That's the medial epicondyle. So you have a capitulum, the trochlea, and then the medial epicondyle. If you look on the posterior side, you can't really see it on the anterior side. There is a lateral epicondyle. So you can kind of make it out over here. It's kind of hard to see it here. So you have a medial and lateral epicondyle, okay? Those are those bony protrusions at the distal end of the humerus. And then there are two fossa that I want you to know, and these are going to be important again when we form the elbow joint. So there is a fossa on the anterior side and a fossa on the posterior side. So the fossa on the anterior side is the coronoid fossa. All right, so you can kind of see that right here. And then on the posterior side is the olecranon fossa. And again, all of this is going to be pulled together. All of these concepts are going to come together when you see how the radius and the ulna articulate with this bone. Okay, so these fossa are going to be important. Fossa are usually areas where you're in particularly in the limbs, where other bones are going to come and articulate. So those are the features of the humerus. Start working on those in the lab. And as always, study guides are very, very helpful. If you can take these images and drop it into a study guide, labeled and unlabeled, you can practice writing out these features over and over again so that you have a way to memorize them. All right. So now the second part of the lecture is going to be talking about the muscles of the pectoral girdle. So don't forget that the pectoral girdle is the scapula and the clavicle. Okay, the humerus is not part of the pectoral girdle, but it is just the additional bone that I went over today so that the next lecture isn't as long. So we are going to talk about the muscles that are attaching to these bones. All right, this is one of those slides that this is not something I'm going to quiz you on or test you on. I just add it here so that if you're not familiar with the actions when you're looking at the lab manual, because again, you need to know the muscles and their actions. If those actions don't sound familiar to you, this picture will tell you what those actions look like. Okay, so this is what the actions look like at the shoulder and the scapula. We always have flexion and extension. This is adduction and abduction. So abduction is moving your arms up, and adduction is moving them back down to your side. You also have abduction and adduction of the scapula. And so, although this isn't written or shown exactly, but when you move your shoulder blades, your scapula together and make them closer to the midline, that is adduction. So squeezing the scapula closer to the midline, you can make that movement as you're sitting here listening to this lecture. And when the scapula goes further apart, that is abduction, away from the midline. So this is closer to the midline. And this is essentially what this movement does. It brings the scapula closer to the midline or away from the midline. So if you make those motions, since you can't see me, that might be helpful so that you can feel your scapula moving. Another movement that the scapula has is elevation, bringing your shoulders up, and depressing, bringing your shoulders back down. All right, let's talk about the muscles. I'm going to talk about the origins and insertions, but again, please double check with the lab activity for what you actually need to memorize. It's always going to be the muscle and the action, And if I decide that we should know the origin and insertion, I will highlight it in the lab activity. All right, one of the muscles that moves the scapula is the levator scapulae. This is a very deep muscle, and it's very difficult to see on the cadavers. I'm not even sure that we can see it. So we may not be able to identify this muscle, but just know its action. So the levator scapulae, it originates at C1 and C4. So you can see that happening here, and it's inserting into the scapula. Now, if this muscle shortens, if it contracts, right, if it gets shorter this way, what is it going to do? It's going to elevate the scapula. All right, now we're going to move on to pectoralis major and minor. You could see the pectoralis major and minor when we were looking at the cadaver the first day, but I will point it out because I really didn't point it out to you. We were just doing a quick overview on the entire cadaver, but you can see the pectoralis minor and the major. The one thing, I think I told you this before, the minors are usually smaller than the majors, and sometimes the minor is above the major. In this case, the minor is deeper to the major, okay? So it sits underneath the major. You have to move the pectoralis major out of the way to see the pectoralis minor. So it originates at ribs 3 through 5, so you can see it here. And it is inserting into the scapula right here. So if this muscle shortens, what is it going to do? It's going to pull the scapula forward. So here is a picture showing you pectoralis minor and pectoralis major. So pectoralis minor sits deep to pectoralis major. All right, here are a couple other muscles that are very deep as well, but you can see these on the cadaver. They are nicely isolated and dissected, so I will be able to show you the rhomboideus major and minor. In this case, the rhomboideus major and minor do follow the rules that I was telling you about. Rhomboideus major is bigger than the rhomboideus minor, and rhomboideus minor sits above the major. So here is rhomboideus major, here is rhomboideus minor. They originate on the cervical and thoracic vertebrae, as you can see here. They're inserting into the scapula. And so the action, if that muscle were to contract, is to adduct. It's going to pull the scapula closer to the midline. And then you get some rotation, medial rotation of the scapula. Those are the rhomboideus major and minor muscles. Again, always remember that images in your book or anywhere where you might find images, usually the left side and the right side will be different. So the right side or one side will always show you more superficial muscles, and then the other side will show you deeper muscles. So I know these images I'm using right here are not from your book because I wanted you to see the muscle in its isolated form, but always keep in the back of your head the knowledge that there are layers upon layers of muscle, and some of them are deeper than others. So it's always good to know if they're deep or superficial. All right, another muscle that moves, that's involved in moving the scapula, is the serratus anterior. This muscle originates at the ribs. You can see how it sits here on the ribs. It inserts into the side of the scapula, and it's going to pull the scapula forward. So this is going to be abduction. The trapezius, which we talked about when we were talking about the vertebral column, because it's involved in extending the neck, also is involved in moving the scapula. So we'll revisit the trapezius, and I'll show you it. It's dissected nicely on the cadaver. Again, it originates at the occipital bone. We talked about that, as well as some of the vertebrae, cervical vertebrae and thoracic vertebrae. it inserts into both the scapula and the clavicle. It's a very large muscle, and it's going to elevate the scapula. It's also going to have, it also has the ability to extend the neck. And here is pectoralis major. We talked about pectoralis minor. Pectoralis major has a different action because this muscle, as big as it is inserting into the humerus. So we are switching over, so make note, we are now talking about muscles that involve movement of the humerus, the upper arm. So the pectoralis minor does not have any movement for the humerus. The pectoralis major does. So this is a very large muscle that originates at the clavicle, the sternum, and some of the ribs. It inserts just here into the humerus, and this muscle is involved in flexion and adduction, pulling the arm this way. We also talked about the latissimus dorsi when we were talking about the vertebral column. This is a muscle that originates on the vertebral column. It inserts also on the humerus here, and its action is to extend the humerus and adduct the arms. Oh. Shoot, sorry. The deltoid muscle. This is another one that is involved in moving the humerus. It originates at the clavicle and the scapula. It inserts into that deltoid tuberosity of the humerus that I just went over. And the actions are lateral and medial rotation and abduction of the arms. So the arms are going to move this way. All right, now we're going to talk about some of the muscles that are involved in movement of the humerus, and I mentioned where these muscles were located when I went over the scapula. So now we're kind of coming full circle. So if you remember the supraspinatus fossa, this is the supraspinatus muscle that sits in that fossa. So it originates at the scapula. It's going to insert, remember, I told you about the greater and lesser tubercles of the humerus. This one's inserting, I gotta shut the door, hold on. Okay, so this one inserts into the greater tubercle of the humerus that I talked about. This muscle has to do with abduction and rotating the arm laterally. So the movement is abduction. The infraspinatus, remember the infraspinatus fossa, that is the muscle that sits in that region. It also inserts into the greater tubercle of the humerus, and it is involved in rotating the arm laterally. We have a series of muscles called the teres minor and teres major. There is a major difference between teres minor and teres major that I definitely want you to know. So I'm going to kind of go over teres major and minor, and then I'm going to point out why they are so different. Let's talk about teres minor first, and it's going to have to do with where this muscle inserts that makes this muscle unique. So teres minor inserts into that greater tubercle, again, of the humerus, and you can see that it originates here at the scapula, and it has to do with rotating the arm laterally. Here is teres major. So what I want you to take note right now before I go into the details about it is where the insertion site is on the humerus. So you can see teres minor inserts more towards where the shoulder is compared to teres major. This is going to be important when we start to talk about the rotator cuff muscles. Okay, teres major is not inserting into the shoulder area. So it's a little bit lower on the humerus. And this is adduction, moving the arm this way and rotating it medially. Subscapularis, if you remember the subscapularis fossa, this is going to insert into the lesser tubercle of the humerus. We're going to get medial rotation of the arm. All right, so we're going to talk a little bit more about this joint and what stabilizes this joint. Because as I mentioned, that glenoid fossa is a very shallow depression. So the cavity is not very deep for the head of this humerus. So it's not very stable. So the muscles around it are what is going to help stabilize this joint. All right, so this is an image. It allows you to see some of the muscles that are present here. You can see some of the muscles, and you can see just how shallow. Here is the scapula, and here is the head of the humerus. You can see just how shallow that ball and socket joint is and how unstable it really can become if we don't have the proper muscle attachment and ligament attachment. So there are a series of muscles, and you can't really appreciate it from this image, that are going to come around and hug onto the head of the humerus and kind of hold it in place, keep it attached to the scapula and in that joint. So they're going to kind of come and wrap around. Remember where that greater tubercle was, and pull that humerus toward that socket. So the muscles that do that are called the rotator cuff muscles. These are the muscles that are going to wrap around, so you can kind of see them coming here, wrapping around. The tendons of the muscles are attaching to the head of the humerus and hugging it and pulling it and keeping it in place. So there are 4 muscles that are involved in stabilizing this glenohumeral joint. And there's an acronym for them, and that is the humerus sits on the scapula. And sits is SI. It's not in the right order, and I apologize. I just learned about this acronym, sits. So this can remind you of the 4 muscles that make up the rotator cuff. Those 4 muscles are the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. Please know the muscles of the rotator cuff. They are not teres major. Teres major comes to right about here. It is not the deltoid muscle either. The muscles that have to do with the rotator cuff have the acronym SITS. The humerus sits on the scapula. These are the muscles that stabilize this joint. And they are inserting into the greater tubercle, 3 of them are, and 1 of them is inserting into the lesser tubercle to secure the humerus into that joint. There are a couple other features that stabilize this joint besides muscles. I didn't go over a lot of ligaments that attach to this glenohumeral joint because of time. There are a lot of ligaments that do stabilize this joint. I did go over the muscles, which is what you're seeing here in pink, that help to stabilize this joint. This slide is a reminder that it is a synovial joint, so there is a capsule around this entire joint, so that is what you're seeing here, okay? And that helps to deepen the socket, right? Because the glenoid cavity is very shallow. This is very shallow. But the capsule, along with the muscles, help deepen the socket. And then there's one other feature that I want to point out, and that is called the glenoid labrum. Okay, labrum means lip in Latin. So it is a lip, it is fibrocartilage. It's like an O-ring that sits around the glenoid fossa that helps to deepen this socket. It sits on the rim of the glenoid fossa, okay? That's what the glenoid labrum does. Here's another picture Glenoid labrum tears are somewhat common, but you can see that it sits like an O-ring on top. So let me take you back to one other picture. Oh no, I'm going to take you back to this picture. So this is my last comment for this lecture, and then we'll wrap this up. But shoulder dislocations are probably one of the most common things that can happen. And if a shoulder is going to dislocate, you can almost tell from this picture how it's going to dislocate. The weakest area of this glenoid cavity is this area down here. This is the weakest area. There's no muscle. There's not a lot of ligaments here. So usually if you have a dislocation, the shoulder is going to drop inferiorly, and it's going to be in the anterior position. So that's usually how the dislocation is going to happen. It's going to be inferior and anterior. That's the most common type of dislocation because there's no muscles or tendons in that area. All right, so I'm going to wrap this up. The next lecture is going to be on the radius and the ulna. We'll talk about the wrist bones as well as the digits and the muscles of the arm.